हाँ ठीक है. So good evening, sir.
Medi classes.
Good evening. Good evening. How are you?
Medi classes.
हाँ, Medi classes. So you have bought the Zoom for your all webinars.
Yes, we do. We've been doing for 2 years now. Yeah, जो हम लोग की जितनी classes होती हैं and everything we do it through regularly through Zoom. All our conferences are through Zoom and we stream in our website. उसके through हम लोग करते हैं.
How much does it cost?
जो annual cost is around, I think जो हम लोगों का इसमें there are meeting along with the conference for people is around annual is around 50,000 के करीब.
अच्छा, 50,000.
But it is good in that sense कि recordings भी मिलते हैं, so a lot of our sessions are recorded, वो easily हो जाता है, and then you can use it for teaching, posting up later on.
अच्छा.
Weekly lectures हम लोगों के Zoom से ही होते हैं.
हाँ हाँ, वो भी सारे Zoom से ही होते हैं. And if we buy, we can add how many people at one meeting? 100 people.
इसमें you can have, अब ये वाला plan 100 people का है, 100 लोगों का है. और उसके अगर ज्यादा चाहिए तो what people do is that they take the speakers in the core group so that disturbance is less and then you can stream it in different places. वो कर सकते हैं. उसमें फिर unlimited attendees होगा YouTube के through या फिर in different channels you can use it.
अच्छा. DIAP ऐसे सर्विस प्रोवाइड कर रहा था, सेंट्रल IAP भी.
Okay. हाँ हाँ.
हाँ, वो भी प्रोवाइड कर रहे थे कि आप अगर करवाना चाहते हैं तो आप हमसे मतलब ले सकते हैं हेल्प.
Okay. And how much do they charge anything for that?
They were not charging anything. They were just कि local branches को एक as a support they were giving.
Okay.
If you want any, हाँ.
हाँ. उसमें थोड़ा सा यही है कि फिर आपको उनके पार हर बार जाना पड़ेगा for all the thing and all.
Actually they appoint someone for everything. So one person is appointed by their. उन्होंने जिस टीम को I think hire किया है, उससे one person is appointed and he will be helping with everything.
Okay. Sure.
That was the plan. I think वो उनका 1 year का plan होगा and they might be utilizing their funds. Next year देखते हैं क्या होता है. सर next year एक सर हम लोग को full सर मतलब virtual नहीं, actual CME सर चाहिए.
We will plan up, जैसे हम लोग का एक practical pediatric endocrine course होता है पूरा, that we'll plan. इलाहाबाद we done I think 2018 or something we did.
हुआ था सर, हाँ 2 साल जी सर हुआ था.
So we'll do it at that time.
13 participants हो गए.
So panelists में I think Dr. Maurya and Dr. Ashok आ गए हैं, and attendees.
Good evening, sir.
Good evening. कैसे हैं डॉक्टर?
मैं ठीक हूँ सर, आप बताइए.
बस बहुत बढ़िया, बहुत बढ़िया. We had done a program I think many years ago जब आप secretary थे.
जी सर, जी. आजकल तो सर पैंडेमिक के टाइम पे और आदमी कुछ ज्यादा कुछ पढ़ नहीं रहा है, कुछ कर नहीं रहा, अपने कोरोना के बारे में ही सोच रहा है। वैक्सीन इज गोइंग टू बी हार्ड। सर इज देयर एनी एंडोक्राइन इफेक्ट ऑफ कोरोना?
मतलब दोनों तरफ से है कि इफ somebody is obese there is a much higher chance of cytokine storm और वो सब फैक्टर्स ज्यादा होते हैं। डायरेक्ट इफेक्ट ऑफ कोविड ऑन द विटामिन डी पे भी स्टडीज है, बट मोर ऑफ एसोसिएशन स्टडीज की इफ यू आर डेफिशिएंट यू मे हैव मोर चांस ऑफ गेटिंग द इन्फेक्शन और आपको ज्यादा सीवियर इन्फेक्शन में भी देयर, बट इट्स नॉट लाइक अ कॉज एंड इफेक्ट सॉर्ट ऑफ अ थिंग। टाइप 1 में भी इनिशियली देयर वाज सम सस्पिशन दैट इट मे इंक्रीज द रिस्क ऑफ टाइप 1, वो अभी तक आया नहीं है, प्रूव नहीं है।
अच्छा सर।
तो डॉक्टर मनीषा यू कैन, जब भी आप होगा आप मैसेज कर दीजिएगा, आई विल ऐड द पर्सन टू द पैनल जो आपको लगता है जो ऐड हो रहे हैं लोग बाद में ड्यूरिंग द टॉक।
जी सर, जी सर।
we can do it.
चैट बॉक्स में ना सर?
You can send through chat to privately to me also directly, then I'll
जी सर।
so shall we start in some time? When do we plan?
हाँ सर, आई थिंक टाइम तो हो गया है।
आई थिंक सर वेट फॉर 2 or 3 more minutes।
डॉक्टर घनश्याम नहीं आए सर, बस मैं उनको कॉल कर लेती हूँ एक बार।
ठीक, श्योर, ओके। Dr. Manisha, I think you're muted.
ये अनम्यूट हो गया आई थिंक। आ रही है मेरी आवाज? सर डॉक्टर धर्मेंद्र कुमार से को ले लीजिए सर पैनलिस्ट में,
ठीक।
एंड डॉक्टर CM पांडे। Dr. Parvati Murthy.
Okay. डॉक्टर मिश्रा भी हैं, पीसी मिश्रा।
पीसी मिश्रा, उनको देखा नहीं नाम मैंने। हाँ सर, डॉक्टर पीसी मिश्रा। उनका ज्वाइन नहीं हो पा रहा है, डॉक्टर घनश्याम मिश्रा का। अभी कॉल किया था, वो बोल रहे थे हो नहीं पा रहा है।
तो shall we start?
हाँ सर, मैं एक बार पूछ लेती हूँ उनसे, वो पता नहीं उनको क्या दिक्कत हो रही है। पता नहीं उनका क्यों नहीं हो पा रहा है। कितने पार्टिसिपेंट्स हो गए? 24। उनका नहीं आया ना अभी। आए नहीं सर। सर फिर हम लोग स्टार्ट करें?
Yeah, I think we should start. वो आ जाएंगे तो बीच में हम लोग, क्योंकि after every session we'll take Q&A, growth, और उसके बाद तो he can come at that point.
जी सर, जी सर, जी सर, जी सर।
Let's start. Okay.
Respected seniors, Professor P.C. Mishra sir, Dr. D.K. Singh sir, Dr. C.M. Pandey sir, Dr. Paritosh Mishra, and dear students, the senior pediatricians. Today, IAP Allahabad is very happy that we have invited Dr. Anurag Vajpayee for the very interesting topic, pediatric endocrinology. And this webinar will be going to be very interesting, as we have always heard him that it's so clear and so interesting are his topic. Let me introduce Dr. Anurag Vajpayee. Dr. Anurag Vajpayee is a senior consultant pediatric and adolescent endocrinology in Regency Hospital Limited, Kanpur, and Fortis Memorial Research Institute, Gurgaon. He was secretary and treasurer of ISPAE 2017 and 18. He was secretary of Grow Society and IAP Kanpur 2012 and 13. He is also director of Medi classes, the very interesting classes, and these classes are very helpful to all new learners and even everyone, I think, who is practicing pediatrics. I have been doing these classes and these are very interesting. And he is a senior editor in endocrinology and Indian Journal of Pediatrics. He has achieved Sorrel Catherine Freeman Prize for Best Postgraduate in Pediatrics at AIMS, and he did FRACP from Royal Australasian College of Physicians. He's trained at Royal Children's Hospital, Melbourne. He is also editor of 5 books related to pediatric endocrinology. He has book chapters in 36 books in pediatric endocrinology, and more than 40 index publications are under his name. over 300 presentations in state and national and international conference. Although I think these are very less, he's teaching every week. He's so interested in academics that we can hear him every week, and he's with full energy. He's always there. Thank you, sir, for here. And with him, we are also having. Wait, sir. Dr. Prateek Sen, Dr. Sayan Banerjee, Dr. Naveen Narayanan. They are fellow in pediatric endocrinology in Regency, CDER. They will be also, they are also faculty in this webinar, and they will be discussing the cases along with Dr. Anurag Vajpayee. I welcome everyone. Thank you, sir. I request Professor P.C. Mishra, sir, to just say a few words for all of us. Professor P.C. Mishra, sir.
Hello.
Ji, sir.
Am I audible to all?
Ji, sir. Ji, sir.
I welcome Dr. Anurag Vajpayee to Allahabad Indian Academy of Pediatrics today for his lecture on pediatric endocrinology. I remember in 2011, he had a pediatric endocrinology session here in Allahabad under IAP banner, and that was very interesting. I recognize and appreciate his ability, his knowledge, and his deep perception in the field of pediatric endocrinology. Thank you very much for accepting our invitation, Dr. Vajpayee. Thank you.
Professor P.C. Mishra, sir. Today we are also having Dr. D.K. Singh with us. So please say a few words. He's superintendent in Super Speciality Postgraduate Institute in Noida. Sir.
Professor D.K. Singh has been...
Good evening, sir. And good
there.
evening, everyone. Yeah, good evening, everyone. Thank you, Manisha. I've listened to Dr. Vajpayee many times in the past. I think this system is going to be very useful for all of us, not only for newcomers, but also to senior people also. So I welcome Dr. Vajpayee. Thank you.
Thank you, sir. Thank you very much, sir. So now, sir, you can start with the session.
First of all, I have to thank the entire team of Allahabad Academy of Pediatrics for inviting me for this program. Especially Dr. Manisha was really coordinated a lot with regards to the program. Dr. Ghanshyam, Dr. Mishra, and Dr. Singh for the kind words of introduction. So the topic today is very intriguing and interesting. So what we're going to do over the next 1.5 to 2 hours or so is to go through the entire aspect of pediatric endocrinology, ranging from growth, thyroid, puberty, glucose, and calcium, using interesting cases and ways in which it becomes easy for people to really manage in that regards, and something which there will be a carry-home message with regards to each and every aspect. So we have been working in terms of awareness of pediatric endocrinology for the last 12 years or so through our Growth Society, which now has a learning portal, learning.growthsociety.in, which has got extensive resources related to pediatric endocrinology in different aspects. You can all go and have a look at it. We have multiple courses on pediatric endocrinology. This is our flagship course, a 2-year course in pediatric endocrinology, covering everything, including a number of videos, animated lectures, quizzes, case scenarios. Along with that, we recently have launched a pediatric endocrinology for postgraduates, a 3-year program specifically for the postgraduate students. Again, using a lot of these educational resources. We have a Mediclasses Master Pediatric Endocrinology book, which you can have a look both in print form as well as Kindle edition. Recently, we have come up with a practical pediatric endocrinology under the IJP banner, more targeted towards pediatrician. Again, a book which is available on the net, both in the form of print and Kindle version as well. And the one which we'll be using today is our Mediclasses app, which basically is a new way of managing patients and transferring knowledge in terms of hands-on approach. So this Mediclasses app is available on both Android and iOS store. It uses a number of approach pathways, management pathways, calculators to cover each and every aspect of pediatric endocrinology, right from growth chart interpretation to bone age assessment to decay management to a lot of other factors which will use that. It is basically a very simple tool in which you can just go into a different part, answer a few questions and get your queries sorted out at that point in time. We'll use it through the course of the presentation. The discussion today is going to cover pretty much most of the parts of pediatric endocrinology. It will be entirely practical. So we'll mainly be having some base, and then we'll talk about cases. And so we'll talk about growth, decay, thyroid, puberty, and calcium. And to have the discussion going, we have got Dr. Prateek Singh, Dr. Sayan Banerjee, and Dr. Naveen Narayanan, who are fellows currently at our department in pediatric endocrinology at Kanpur. From there, so we'll start right away from growth, which is the most common problem which a pediatrician will encounter. A 12-year-old girl, height of 132 centimeters and weight of 20 kgs. Now, this is a common problem which a pediatrician will encounter. What we need to understand is that growth failure is common. 2.5% of all children will be short. 80% of them will be physiological, for which no workup is required. And 10% may have a significant pathology if you're talking about from a pediatrician's perspective. And the main aim of this evaluation is not to do unnecessary investigation in those 80% while not missing those 10%. So this is very, very important, and this is what we're going to do over the next course of time. So when you talk about growth failure, basically, as we said, majority of them are physiological, which is constitutional delay of puberty and growth, in that the individual is growing, but growing slowly. They will have slightly delayed bone age. They will carry on growing for a long time. So in a way, they will be short, but they will not be short for their bone age. Familial short stature is another variant in which they will be short because the family is short, and they also will have a normal bone age. So they may be short for their bone age, but they will not be short for family. And when we are seeing these terms, these are very important when we talk about how to interpret growth. CDJP, not short for bone age, familial, not short for family. And this is how we'll come back to this, how this becomes important. Then we talk about pathological, which is around 10 to 20% of cases encountered by pediatricians. You will have a small section who will have primary causes like skeletal dysplasia, SGA, easy to identify. And then you have secondary causes, which could be either nutritional or environmental, including malnutrition, systemic illness, and other factors, and endocrine. The major differentiation between endocrine and nutrition is also very, very important. Endocrine causes will have a lesser effect of weight. They will be short and plump, while those who have a nutritional cause will be short and lean, and weight becomes important in that regard. So 3 questions which a pediatrician has to answer when evaluating a child who is short is it growth failure? Is it pathological? And if it is pathological, is it secondary or primary? Is it endocrine? And finally, what's the cause? So to identify growth failure, all you have to do is to plot on the chart. Now, there had been a huge debate, but now IAP 2015 is the clear-cut chart. Our study was going to be recently published in Indian Pediatrics has clearly shown that IAP 2015 is much better predictor of pathology as compared to the WHO or the CDC criteria. So if you're using the WHO and CDC charts, you will label more children as short, but many of them will not have an underlying disease. So use IAP 2015 and evaluate if you have 3 things. The first scenario, very short, height is much below the 3rd percentile. Second, short and not growing. So if somebody is between the -2 to -3 standard deviation score deviating away, you will do an evaluation. And very importantly, if a child is crossing 2 or more percentile lines between the age of 2 years to puberty, again, an evaluation is required in that setting, and that becomes important. Now, how do we quantify that in real terms? So we have all been talking about percentiles. What I'm going to do is to take you through a more precise, a more objective way of assessing growth, and that is standard deviation score. Because when you say percentile less than 3rd percentile, it can be 0.001 percentile also, and it's very difficult to interpret. So what we use now is standard deviation score, and this is our data of around 870 children. What we found was that if the height is more than -2 standard deviation score, the chance of pathology is minimal, 2.5%. As soon as the height goes between -2 to -3, it becomes 42%. And if the height is less than -3 standard deviation, it becomes 80%. So if you now want to look at it in a different form, you can use a traffic light approach. If the height SDS is more than -2, you may not do any evaluation if there are no other clinical pointers. -2 to -3, you need to observe and evaluate, and less than -3, you can't wait, you have to evaluate. Now, how do you get the SDS? A lot of applications are giving you height SDS based upon different criteria which you can use. We'll talk about how our Mediclass's growth interpreter will work in that regards. So once you know that this child is short, the next question is whether it is physiological or pathological. To answer those questions, you have to look at three things. One is the growth chart, second is the pubertal status, and third is the bone age. Now, all three of them are complicated and often cause errors in that regard. So what we have done is to simplify growth interpretation, pubertal assessment, and bone age assessment using our app, which you can do directly right at the time of consultation to get the immediate results. We'll talk about pubertal assessment a bit later, which Prateek will talk about when we talk about pubertal disorders. So what do we do in terms of chart? So when you're looking at a chart, you have to look at three things. First, what is the absolute status of the height? How is the child compared to the population? And this is percentile or a standard deviation score. The second is how is he comparing to the parents? So what you do is that you calculate target height, which is the mother's height and father's height divided by 2. You add 6.5 for boys and subtract 6.5 for girls, which will give you the target height, and then you can take a target height standard deviation score and correct for the family, which will give you the information how the child is compared to the family. And then you look at the nutritional effect, whether you have got a major effect on weight or on height. And for that, you look at the height, age, and the weight age. So height age is the age at which the current height is the 50th percentile. If you have a predominant effect on the weight age, it is nutritional. If you have a predominant effect on the height age, it is basically endocrine. And what we'll go through is BMI SDS. So these are the three conventional criteria: percentile, target height, and weight age. To ensure that we have an objective assessment, we'll be using height SDS, corrected height SDS, and BMI SDS to identify these three, and this will give you a clear-cut picture in that regards. Now, as I said, the next question is it familial short stature? So studies have clearly shown that if your height standard deviation score is within 1.5 standard deviation score or plus minus 9 centimeters of the target height, you are familial. So the most important parameter to look at is corrected height SDS. If it is normal, that means you are normal for the family, it is familial short stature. The next question is constitutional delay of puberty and growth. And our data suggests that if your height is normal for the bone age, that is your height standard deviation score for bone age is less than -2, you are most likely CDGP. So what you're looking basically at first, how is the child for the population, how is the child for the family, and finally, how is the child for the bone age? And these three answers will exclude all your physiological causes in that regards. The next step, of course, is it endocrine or is it a nutritional cause? For that, you can look at height, age, and weight age. And what we found that if your BMI SDS is more than -1, it is most likely an endocrine cause of growth failure. So just three parameters will predict which way you're going. Not even doing a single investigation in this setting will help you out. One very important investigation which is relevant is a bone age assessment. And unfortunately, we are not really trained in terms of bone age assessment. The radiologists are also not very well trained, and they tend to do a lot of errors when they're assessing the bone age. Now, basically, when you're looking at bone age, the most important thing to look at is that you're talking about a non-dominant hand and wrist. And according to the age, you have to focus on different areas of the bones. So the growth or the maturation of the bone happens basically from appearance happens from proximal to distal, and fusion happens from distal to proximal. So if you want to look at the bone age assessment in a younger child, you are talking about smaller bones, basically the carpal bones and the small bones. As the age grows up, you're talking about these phalanges. And if you want to talk about fusion, the tip of the phalanges become absolutely important in that perspective. So the most important areas to look at the bone age are actually the epiphysis and how the epiphysis are in comparison to the metaphysis. Now, there is a very good video that we've developed on bone age assessment, which is 1 hour, which is available on the YouTube. You can have a look at it. But having said that, it is not very easy. The standardized way of doing bone age assessment are complicated. They require extensive training and they require a lot of time. So what we decided was to develop a novel way of doing a bone age assessment, and we did it in a proper structured fashion of a study design in which we used 300 X-rays to develop a bone age method. Dr. Riddhi did a lot of work on that and then used 5 sites to identify the bone age assessment. So what our Mediclass's bone age application does is basically it compares these sites. There are 5 basic sites which have to be compared: the radius, the ulna, the proximal phalanx, the thumb, and you have to compare this to a panel of X-rays. You don't have to do anything, just compare to that particular panel of X-rays. So there will be these 5 sites which you have to compare. Once you do that, so these are basically the middle finger of the middle phalanx, middle finger proximal phalanx, as I said, thumb proximal phalanx, radius proximal phalanx, radius and ulna. And once you compare those, you basically very easily get a bone age result which has been validated against the gold standard Tanner Whitehouse and found to be very accurate and precise with limited individual variability. Very importantly, even novel users who have not done bone age assessment have been assessment within 2 minutes time. So this is a new way of bone age assessment which you can do in our office. Very quick, very effective, and I'll encourage all of you to have a look at this application to do that, because bone age is crucial. So based upon that, now we have developed an algorithm which basically helps us minimize the investigation and use clinical parameter to reach the diagnosis, and this is particularly suited for resource poor countries, especially we don't want to do unnecessary investigation. So what we use is do a height SDS. If it is more than -2, or if you are comfortable with percentile more than 3rd percentile, only if there are clinical pointers do a evaluation, otherwise no evaluation is required. If your height SDS is -2 to -3, the next step is this child is short. Is the child short for the family or not? So you use a corrected height SDS. If the child is not short for the family, this is familial. If the child is short for the family, the next question is he or she short for the bone? So if the bone age is basically also compromised, this is constitutional delay. If the bone age is basically not compromised, then you start doing the workup. So around 80% of your cases will go off here without a single investigation except the bone age, which is essential. Now you do these screening tests, the CBC, ALT, creatinine, electrolytes. We want to do TTG in all. Thyroid, very important. Blood gas only if the child is below 3 years, not beyond that, because RTA does not present. So we have a very limited workup. We are not doing IGF-1. It is an expensive investigation, not helping at all. Now, if these are normal, follow up for around 6 months to 12 months and see how the child is growing. Or if the child is very short, we don't want to wait, because 80% chance of pathology. In that setting, you look at facies and body proportion. If they are normal, do the same screening tests. And then based upon further workup, depends upon the BMI. If the BMI is compromised, you're looking at nutritional cause, which include IgA. So we are not doing IgA at the beginning, but at follow-up and some other workup. And if they are normal, you then go to karyotype in girls and growth hormone stimulation. So this basically is an approach which is clinical, very, very different from the international recommendation, which talk about huge amount of workup right from the beginning, and you can make a diagnosis in that regards. So based upon this, what we actually did was that, so what you do is that based upon that, you can use the same approach in our app. It just asks question and answers, and you just answer that the screening tests are normal. It mentions the tests which are to be done, what are the BMI SDS, and then finally you decide on what the workup, and you will then go into a diagnosis in that regards, and all these tests are available. So this basically is the approach pathway, which really helps us identify a particular diagnosis, and you will get the diagnosis at the end. Now, we evaluated this in our group of children, and what we found that there was around 90% and above concordance with the diagnosis of clinical diagnosis and the app diagnosis. So this app is pretty good in predicting the workup, and it is limiting the cost of investigation, and you can have a look at that regards. So now what we'll do is that we'll invite Dr. Pratik to start off with regards to the cases. Dr. Pratik?
Yes, sir. Thank you, sir. So we begin with this 12-year-old girl with a height of 132 centimeters. Now, as is evident here that the mid-parental height is around 153 centimeters. So once we plot this on a growth chart, now if we see a growth chart in the face, it looks like the girl has short stature. But the next step is to plot it for the parent's height. So once we plot the girl, so we see the MPH, which goes to 153. Now, if we compare her height to her parent's height, it does not seem that short. If you look over here, she does not seem to be falling below the mid-parental height, SDS. So what do we do next? So if you look at this girl, she is not short for her parents, and she's falling in the growth according to her parents. So this is probably, we plot this height age, her height age is 9 years, her weight age is 9 years. So both are at around 9 years. She's falling in the parental SDS. So this is probably a familial short stature, which looks like as the first when we look at it.
Yeah, so Dr. Pratik has very clearly shown that this case, basically the first question, is the child short for the population? Yes. Is she short for the family? No. So the answer is this is a familial short stature. So if you plot on the chart, no workup is required. Of course, you will look at the pubertal status and decide, but definitely no workup required at this point of time. Now, if you look at the application, all you have to do is to basically enter these data and you will get this interpretation. All these things will come up, and then we will also have a final diagnosis as well, which says that this is a likely familial short stature, because the corrected height standard deviation score is actually more than -1.5. So same thing that you get from all the interpretation in the chart can very easily be get if you just put the data in there, and you'll get the results from there. So this is the familial short stature. Next case, Dr. Pratik.
Yes, sir. So a 12-year-old girl who was 120 centimeters tall, mother is 157, father is 170, but her bone age is at 10 years of age.
So what do you think, Dr. Pratik, the workup showed hemoglobin of 10.2?
Yes, so
was normal.
Yes, initial workup was normal in the form of hemoglobin, TSH and TD. Physician somewhere did an IGF level which came low and a basal growth low. So I would do further evaluation. First of all, before doing anything, we need to plot this child on a growth chart and see whether what is happening.
So the first question, of course, would be whether this child is really short. So at 12 years, 120 is really short. She will be short for the family, definitely. The next question would be whether it's a nutritional or an endocrine pattern. So if you put these data in the growth interpreter, this is the chart that you can see. So what do you find, Dr. Pratik, here?
Yeah, so what we are finding here is, look, if we look at the height age and bone age, it is looking like a nutritional pattern more than an actually endocrine pattern. The BMI
so the weight is very much compromised. If you see, the weight standard deviation score is hugely low, and the BMI SDS is actually lower than -1. So this is what is showing as a nutritional. So this is a short and lean child. Any most important thing to look at in a short child is the weight. If your weight is compromised, this is nutritional, and the weight is normal, it is endocrine. So now in the light of this, what do you think, Dr. Pratik, from there?
Yes, so I would, first of all, I would not call this a growth hormone. Clearly, the nutrition is more affected than the endocrine part. And secondly, first of all, a basal growth hormone has no hold. We need to, it would not help us in any way.
And why is the IGF-1 low?
So first of all, in any nutritional causes, we might find low IGF levels.
So this is a 2-3 big messages coming here. IGF-1 is a not at all good investigation in somebody who is having malnutrition, because IGF-1 will be low. So that's why we are not talking about IGF-1 in our algorithm. The second point Dr. Pratik said is that basal growth hormone is a waste of money. Growth hormone is a pulsatile hormone. If you do a single growth hormone, you will miss the deficiency. It is not required, definitely. So what will you do now? This is a nutritional pattern. Your TTG is normal. There is anemia. What else do you like to do here?
So, sir, as you mentioned, TTG is normal, but there is a high pretest probability. I would say that this girl is short, there is anemia, but I'm still hold on to the celiac disease diagnosis. So since could this be a IgA deficiency masking the TTG raise? So I would like to do IgA levels.
IgA levels were undetectable. So again, the message here clearly is that if you have clear-cut nutritional pattern, in our algorithm, we said you do IgA later on. We're not doing IgA from the beginning, but you have to do IgA later on because a reasonable proportion of patients may be IgA deficient, and this will give a false negative diagnosis of the celiac disease in that setting. Next case, Dr. Pratik.
A 10-year-old boy, height 100 centimeters. Now, mother and father are 150 and 163, and the bone age is at 7. So first of all, sir, we need to see whether this boy is short. Of course, 100 centimeters is short. Now, initial investigation showed hemoglobin of 13.2, TSH was normal, and a mildly raised TTG of 32. So for this child, and doctor had started gluten-free, but there was no effect of this gluten-free diet on this child.
Why do you think gluten-free diet did not improve this child?
So as first step, which would be plotting it on a growth chart, which would have shown an endocrine pattern, which would have essentially ruled out a cause of celiac disease. So we need to go.
Dr. Pratik, what he's saying is that his BMI SDS is actually positive. So he is short and plump. This cannot be celiac disease, or very unlikely to be celiac disease. We have to think of a growth hormone deficiency out here. So what if these two cases are basically telling us that basic evaluation of the growth chart, basic growth interpretation can avoid unnecessary mixed diagnosis. And as we now know that TTG of 20 to 200, you have to get a biopsy. Without a biopsy, you should not start gluten-free diet. And if the levels are more than 200, you may consider diagnosing celiac without a biopsy. But usually 20 to 200, you have to do a biopsy. And that is very important. So what happened later was that this child turned out to be a growth hormone deficiency. So again, a big message, if you have a short and a plump child, think of an endocrine cause. Do not rely just on a single TTG level. Do a biopsy before you go ahead in terms of evaluation. So celiac is a common cause, but should be evaluated in an appropriate setting. Again,
a 14-year-old girl who was 120 centimeters tall. Now she came to the OPD with these characteristic features. Now, if you look at the girl, we find height is short, but there are some features which come straight here. Initial investigations were normal, but clinical pointers such as a shield chest, widely spaced nipples, brachymetacarpia, Madelung deformity makes it very clear what the diagnosis is. So the next step, evaluation was done.
So this clearly looks like a Turner syndrome. Now, Turner syndrome is an important differential in girls who present to you with growth failure, and there are guidelines which suggest that every short girl whom you don't have an identifiable cause, do a karyotype. Now, what many people do, as was done in this case, was that FSH was high. So do you think this is sufficient to diagnose Turner syndrome?
No, sir. Every girl who has Turner syndrome needs and warrants a karyotype to look for Y cell line and, of course, to diagnose Turner syndrome.
So while you can diagnose Turner clinically and with a high FSH, it has very importantly, if you miss the Y cell line, the patient will develop a gonadoblastoma. And that's what happened later on in that setting, that she presented later with gonadoblastoma. And that's very important that if you have Turner syndrome in a girl, always do a karyotype. 10% of these girls will have a Y cell line. And if you miss them, they will develop by 15, 16 years a tumor. And that's going to be a big problem. So again, a big message coming out of here. Now we are moving towards a different angle of obesity. Dr. Pratik, what do you think about this case?
So he's a 12-year-old boy. Height is 160 centimeters. Weight is very high at 7 kg. And very importantly, the bone age is at 12 centimeters, at 12 years only. So further, a TSH was done, which came to be 7.9.
So do you think you should start thyroid treatment here?
So there are no clinical features of hypothyroidism. And secondly, a TSH of just 7.9 is indicated more of secondary to obesity rather than it actually being a primary hypothyroidism.
So if you look at the growth interpretation in this child, what you see is that she's tall for the age. And as I said, the most important thing to look at in a short child is the weight. The most important thing to look at in a obese child is to look at the height. If you are tall, it is nutritional. If you are short, it is endocrine. So this does not fit into a thyroid problem. So why do you think his TSH is high?
So as we know, sir, because of obesity, the basal BMR is low. So it is like a technique of a defense reaction to the obesity to increase the BMR.
So this is the effect of obesity and not the cause of the obesity. So unless your TSH is more than 10, you have TPO positivity, you have goiter, don't start treatment. In this setting, it's not required. It is the effect, not the cause of the obesity. This child is tall. He is very unlikely to be because of hypothyroidism in this case. Now, next case, again, obesity. Yeah.
A 12-year-old girl whose height is 130 centimeters, initial tests were normal, but then she presented with rapid weight gain. Now, if you look at the growth chart, there is clear height age is more affected than the weight age, suggesting of an endocrine cause.
So this girl is short and plump endocrine, Cushing syndrome, hypothyroidism, pseudohypoparathyroidism, Turner syndrome. So this you do not reassure, you have to do a proper workup. And if you look at our interpretation as well, put all the data, you will find that this is an endocrine pattern growth failure. You cannot miss this child. Short and plump rare, 98% of obese children do not have a pathology. But 2% may have a pathology, which may be one of these if they are short. This clearly is a case in which the workup showed clearly a Cushing syndrome-like picture, which has to be evaluated. So again, the message, just go to the basics, look at height and weight. The diagnosis will be done in most cases, and these interpretation becomes important in that regard. So thanks a lot, Dr. Prateek, for joining with the group. We'll get you back again on the next session on puberty. We'll now change tracks. This is going to be a very interactive session, so we'll maybe try to put some questions which are there, and we'll see if there are any questions there. So I'll go to the chat.
So one question is there in question answer section.
Yeah. Q&A. Any age considered CDGP? Yes. So generally, CDGP is not just during puberty. It tends to take of these children have a delayed maturity from around 6 years or so. So 6 to 8 years starting girls, I would be a bit wary. But at the age of 5 years, it is unlikely to be CDGP. So I would not be making it a primary factor in that regard. And as I said, the more severe the height effect, if your height SBS is less than -3, it is definitely unlikely to be CDGP in that regards, Dr. Sabeen. Has Dr. Ghanshyam joined in?
No, sir, not yet.
Okay, so we'll take him. Maybe then we'll move forward to the second part on the DK, which is very important. DK is one condition which is a make or break diagnosis, which is there, and it has huge implications in terms of treatment. So now what happens when we have DK and how do we treat it? So the major treatment of DK, the initial part is basically fluids. As soon as you give fluids, the counter-regulatory hormones go down, and therefore the volume expands, and therefore the glucose will fall down by around 100 to 200 milligrams per day. The other thing would be that this is increased glucose, but it is not going to improve your ketoacidosis, for which you have to give insulin to decrease the ketones and the acid in that regards. The problem is if you give participants to mute, if you give too much fluid, there will be a risk of cerebral edema and hyperchloremic metabolic acidosis. If you give too much insulin, there is a risk of hypokalemia. So you need to balance between too little and too much, and this is very, very important in this situation. So what are the problems which happens with DK? The most important is cerebral edema, which basically occurs because of the severe disease, giving too much fluid, giving bicarbonate. Along with that, if there are osmotic shifts. So some people say it's because of the disease per se, but there is also a role of osmolality, which is there in that regards. A major cause of mortality and morbidity. So what we need to do is to decrease the fluid rate and give a slow correction, give mannitol in the right setting. Second major problem is hypokalemia, and this happens once you give insulin, the potassium is shifted into the cells, acidosis becomes better, potassium goes into the cell again. So you have to give potassium right from the beginning. So the initial management itself, so when you start giving the treatment, if your potassium is low, you give normal saline with potassium. the potassium is normal between 3.5 to 6, in that situation, you should start from the hydration phase 2 ml per 100 ml potassium. And that's very, very important. If you do not do that, there will be a significant problem which will happen in DKA. And of course, acidosis can be because of ketosis, infection, but if you give too much fluid, hyperchloremic metabolic acidosis can also happen in that regards, and which may cause a problem. Very importantly, this acidosis improves over time. Do not give soda bicarbonate, because soda bicarbonate is the major risk factor for cellular edema. It is not required and harmful in that setting. There is a risk of infection, there is a risk of thrombosis. So do not put a central line in a child with diabetic ketoacidosis. Never put a central line. If you're putting a central line, very importantly, give a low molecular weight heparin. Otherwise, thrombosis may happen. Infection, as I said, is important, but just leukocytosis does not indicate that there is infection. If you have fever and if you have persistent hemodynamic instability, in that setting, start thinking about infection in that regards. And if you have a sudden onset muscle pain, red color of urine, increase in potassium levels, increase in creatinine, decrease in phosphorus, think of rhabdomyolysis. So the overall management of DKA requires appropriate initiation of fluids, followed by appropriate timely induction of potassium, inclusion of glucose as soon as your glucose levels comes down, and then follow it up with tapering gear on. There has to be a tightrope. So if your fluid becomes less, you will become dehydrated. If you give too much fluid, there will be cerebral edema. If you give too little insulin, you will take time to clear off. If you take too much insulin, you will develop hypokalemia. Now you have a choice of either having a slow correction of dehydration, a slow correction of decay, or developing cerebral edema or hypokalemia. So I think everybody will agree that what we need to do is to go slow. Give less fluid. Never give more than 40 ml per kg in the first 4 hours. Never give more than 3 liters per meter squared per day, because that's a risk factor. Give insulin slower. So people talk about 0.1 unit per kg per day. There are studies which say 0.05 may be definitely good and not bad, and maybe better also. So definitely if there is malnutrition and somebody is less than 1 year, use a lower insulin dose in that regard. So now we're talking about doing less than doing more, because less causes less harm in decay in that regard. But once you manage, you have to monitor for sensorium, which should improve, hydration should improve, urine output should remain normal, sodium should remain stable, potassium should improve, and ketosis should improve. Usually, glucose becomes normal by around 6 to 8 hours, ketones by around 12 hours, and blood gas by around 17-18 hours. If you have a worsening of sensorium, any change in sensorium, think of cerebral edema. Always keep mannitol on the bedside of a child with DKA, because they will otherwise die if you do not give mannitol. Potassium, if you have a fall in potassium, give a push of potassium. And if there is confusion, you decrease the insulin dose, because hypokalemia can kill, acidosis may not kill. If the corrected sodium is not rising or is not stable or falling, risk factor of cellular edema, very important. Urine output decreasing, always think of a possibility of a renal failure. So you have to be very, very careful in those settings in that regards. This is our paper from Indian Pediatrics recently, which shows that cerebral edema is very, very common at diagnosis in our country. The reason for that is that many of these patients are given too much fluids outside. So if somebody is treated outside, somebody has received fluid, you have to be very cautious about cerebral edema, because that can cause a lot of problems in this setting, and you have to be careful about. Having said that, and having spent so much of these talks on DKA across the country, what we try to do is to evaluate what is happening in our own intensive care unit. We took out records for the last 10 years, and we found that a lot of errors were happening in the management of DKA. And these errors were in the form of delayed insulin, delayed bolus, delayed potassium, and this contributed to a number of problems. So if you actually talk about preventable errors, 2/3 of hypoglycemia, around 40% of hypokalemia, and 66% of dehydration could have been prevented if the exact protocol was followed. The problem was that there was a written protocol. Residents were there, so in the initial 1 to 2 hours, by the time they used to contact us, the treatment was started. And like any other branches of acute pediatrics, if you have a problem in the initial phase, it's difficult to catch it up. So there has to be a way in which we can improve the management on that regards. And that's why we have developed a lot of tools for DK as part of our app, which really provide you with step-to-step guidance, which are specific for that patient, which really gives you the clue as well as the dose, the amount, and a lot of factors are there to decide about the initial and follow-up management, which will help us manage DK. And we found that had these clues, these things been taken up, most of these problems could have been prevented. And we are doing now as a prospective study to see how it helps out in that regard. So now we'll start off with a case. Dr. Sayan.
Yes, sir. So a 10-year-old, yes, sir. A 10-year-old girl presented to us with blood sugar levels of around 540. Her pH was 6.9 and she had a dehydration of around 10%. So initially, as you already have mentioned, so we have to mainly focus on the fluid therapy, which consists of a maintenance and a deficit. The fluid therapy in this case has to be corrected over 48 hours generally, because there are no signs of cerebral edema in this child presently. So there are two guidelines which tell us about fluid replacement in a DKA, that is the ISPAD and the BISPED. The difference between the two, I will henceforth say. The ISPAD mainly follows the 4-to-1 Holiday-Segar formula, which you already know. And the deficit is calculated as per the dehydration. As in this case, there was severe dehydration. It was a 10% deficit which was calculated. And the total amount of fluid is calculated as shown on the screen. And it comes out to be around 135 ml per hour in this case. But if I concentrate on the BISPED, it generally goes for a lower fluid volume to prevent the dreaded complication of cerebral edema. And in this case, the maintenance fluid is capped at 40 ml per hour, but the deficit is the same, but it is calculated here as per the pH. If it is less than 7.1, the dehydration is taken as 10%. But if the pH is more than 7.1, the dehydration is taken at 5%. And as per the calculation shown, the BISPED guidelines tell us to give fluid in this case at 105 ml per hour.
Now, assign two questions. One, you say dehydration assessment, which is mainly clinical. Do you think we tend to overestimate dehydration or underestimate dehydration in DK?
So we tend to overestimate dehydration in DK, sir.
You have to be very careful because we don't want to give too much fluid. So when you're actually judging somebody as severe dehydration, you may actually come down a step later. What about the ISPAD, BISPED issues? Now, when you talk about BISPED guidelines, it is developed mainly for management in UK. And they talk about pH of 7.1, less than 7.1, more than 7.1. But if you see at this child who has a pH of 6.9, you cannot extrapolate such a severe DK coming out from the UK guidelines. So basically what I'm trying to say is that if you use BISPED guidelines, we tend to have a sense of under treatment in that perspective, and that can have a significant implications in that regard. So we prefer the use of the ISPAD guidelines, which are better in terms of these severe forms of DK. Yeah. So now if we carry forward in this case, the normal saline was given 10 ml per kg, and then fluid was started as far as the SPAD guidelines is concerned, and insulin was started. So always start insulin infusion. Suppose you don't have an insulin infusion set, what will you do, Sign, in that case?
Sir, pardon, sir, insulin infusion set. So we can go for a IM insulin in this case, sir?
Yes, so if there is no availability of the infusion set, an intramuscular insulin can also be used in that setting. Hourly doses of a rapid acting analog can be considered. So now we have started this treatment. This is how the app will work. You put all the data in, you put the pH, you put the information about CO2, you put the information on potassium. Now all this information is basically taken into consideration by the app, and it decides based upon these information as to what will be the most appropriate treatment modality which is there. And what we've done is that there are 72 components in the algorithm. It tells you whether the DK is there, what is the fluid, how much to be given, what rate, how to monitor in that regards. So now at 8 hours, blood sugar is 200, base excess is -12. What do you do here, Sign?
Sir, at 8 hours, the patient is doing fine. As you already mentioned, the sugar comes down initially within 6 to 8 hours, but the base excess here will persist because the average time taken is around 16 to 18 hours, can take up to 24 hours. But as the sugar has come down to below 200, we need to add 10% dextrose at this point of time.
So very important to add dextrose at the right time, otherwise you will have a huge problem. So this is our follow-up guidelines. It asks again about the same questions, what the sodium and what the other parameters are. And based upon that, we'll give you a guideline. So as soon as your blood glucose is below 300, you add 5% dextrose. Less than 200, you have to add 10% dextrose in this setting. So again, it will talk about foreign corrected sodium and go from there in that situation and change the fluid to 10% dextrose. So this is meant for places in which you don't have a consultation easily available with an intensivist or from an endocrinologist. Anywhere, this works offline. So any remote place can use the same app to get the right information based upon the ISPAD guidelines. Now 20 hours, your blood sugar is 190 and acidosis is still persisting. You said acidosis goes off by around 12 hours, 18 hours. Why is it persisting here, Sayan?
The acidosis can persist due to, as you already have mentioned, we need to rule out renal failure. We need to see if there are any signs of hemodynamic compromise or there are any signs of infection. And then, so for that, we need to confirm the ketone levels to rule out if ketosis is persisting or not. If the ketone levels are less than 2, so we have to check for the anion gap. If it is high, then we can suspect lactic acidosis as the cause for the same. And if it is low, as you already mentioned, hyperchloremic metabolic acidosis is very common. And this is the most likely cause in this case, sir.
So now, because a lot of normal saline which is being given, the chloride level becomes high and there is hyperchloremic metabolic acidosis which persists over time. And that is basically the cause of this acidosis. So what will you do? Will you continue insulin? How long will you continue insulin in this case?
Sir?
So the child is now eating well, accepting he wants to eat.
So the hyperchloremic metabolic acidosis will resolve on its own, sir. If the child is eating well and the ketosis has resolved, we can shift the patient to subcutaneous therapy.
So this is a big message. If the child is having a normal urine output, no fever, no dehydration, accepting orally, mild acidosis, don't bother. This is hyperchloremic. It will wash out by itself over time. Doesn't require much intervention. But if you have persistent ketosis, if your anion gap is high, if urine output is less, of course you have to work up for other causes of acidosis in this regards. Now, post-decay, he was started on a sliding scale insulin. And this is something like 6 hourly. He was given, you check the sugars, give insulin. Based upon the levels, the sugars were fluctuating. What should you do here, Sayan?
So sliding scale exactly has this problem because we retrospectively treat the sugar, not prospectively. So we will shift the patient to a basal bolus regimen as is mainly done nowadays. And then I hope the sugars will get controlled.
And very importantly, the requirement of insulin in the post-decay phase may be 2 to 2.5 units per kg. So start off at a higher dose. Give a long-acting insulin the night before you are shifting. These are all very, very important parameters that will help you reduce the stay in the ICU. By when we have started our basal insulin at night and Glargine and Lispro, we find that we can discharge them within 1 or 2 hours of decay, 1 or 2 days of decay, rather than the earlier admission, which was much longer. So if you want to cut down, use that and you start at a high dose. We've got specific ways in which you can calculate the insulin dose based upon weight very easily and distribute into the basal and the bolus therapy as well in that regard. So thanks, Sayan, for this discussion on decay. And we'll probably stop there for some time and see if there are any questions there coming, Dr. Manisha, and any inputs from the panel. Dr. Manisha, you're muted.
Yes, sir. Yes, sir. So some questions are there here. One of the question is Dr. Rupesh Singh, 5-year-old girl with height below 3rd percentile, weight 3rd percentile, diagnosed as congenital hypothyroidism on levothyroxine since birth. Can congenital hypothyroidism on levothyroxine with normal TFT cause height below 3rd percentile?
It will depend upon when was it picked up and how was it treated over time. So often the diagnosis is late, so it may take a long time to go off. But if the control has been normal for a long time, I would be a bit wary about the same, and we have to look for the other possibilities in that regard.
So Dr. Dharmen has said that pupillary abnormalities are early markers of onset of cerebral edema in decay.
That's true. So I would say there are 3-4 things you have to look at. If your child has received fluids before he has come to you earlier, if the GCS is low, so these are all part of our, that's why we put this in our algorithm. If the GCS is low, right from the beginning, you have to worry about that. If there is bradycardia and hypertension, that's very, very important marker of raised ICT, and anisocoria. So anisocoria happens much later. So I would be very, very bothered about anisocoria. But yes, this is an important thing to look at for cerebral edema in that situation. In that situation.
So next question is from Dr. Vivek Gupta. When to suspect raised ICT and use mannitol during decay? It's the same question, sir.
Yeah, so basically, if you have any fall in sensorium, I think that's the most common thing that we look at. A child's GCS was doing fine and suddenly it falls down, your glucose is normal. Don't think about anything, give mannitol. That's pretty much the state I would say in that regards. If there is brisk reflexes, bradycardia, hypertension, pupillary reflex are abnormal, then of course you do that in that situation as well.
So question from Dr. Ravi Adlakha. Should dextrose be started at 250 or 200 milligram per deciliter?
If the dextrose is, if the glucose level is less than 300, you add dextrose as 5%, less than 200, you add at 10%.
And the next question is, sir, dose of long-acting insulin, I think.
So the dose of long-acting insulin will depend upon the whether the decay is there or not, whether the puberty is there or not. Usually it is around 40 to 50% of the total daily dose. So if you're talking about a 30 kg child who comes to you with decay, we are talking about 60 units of insulin. Maybe I'll give around 27 to 30 as the long-acting and 10 as the rapid-acting insulin or the short-acting insulin in that situation.
So one question is from my side. So one of the patients we started with the basal bolus regime. Initially, according to the books, the doses were start, but the child was not maintaining with that insulin dose. So we had to increase to very high. And after 1 month, he came with hypoglycemia. Suddenly, I think his insulin requirement went down. So what should we do? When to just titrate this?
Yeah. So I think the classical case that you're describing about, basically after decay, the requirement goes up to around 2.5 to 3 units per kg per day. Within 1 week, it is expected to come down to half. And within 2 weeks, it may actually go to around again 1 unit per kg. This is because your glucotoxicity has gone and the child's remaining beta cells have started functioning. So this is like the honeymoon phase which has started appearing. So you have to be very, very cautious. Tell them that when you are starting, it's a very high dose, and the next 1 week or 2, you expect the dose to be half. And if you really caution them out, they will really understand that and then manage accordingly from that perspective.
Weekly follow-up has to be done then.
Yes, definitely. And we have to educate them also with regard to the dose adjustment and other things as well. We are planning to come up soon with a patient application which will be multilingual, which will allow them dose adjustments in type 1 diabetes based upon the doctor input. So this is going to be quite helpful in that you don't need to really connect with them every time. They can do it at their own level.
So when to decrease the dose of insulin at what level? If they are having less than 100, we can decrease insulin level.
I would be even more cautious because I expect the doses to fall down. So if your sugar, let's say fasting was 220 yesterday, and now it has come down to 130, I know if we don't reduce it, next year is going to fall. So the trend becomes important. So the recommendation as far as guidelines is 90 to 140, 150 is the target fasting, and 100 to 180 is the target post-meal value. But if your sugars was 200 and now the cells are improving, you are now at 120, I'll decrease the dose. So, and that too by around 20% or so, 10 to 20%. So this is how the diet is very, very dynamic in the first 2 weeks. So we usually call them after a couple of days, then after a week. So this has to be a close call, and then we educate them also how to monitor and go from.
Thank you, sir. So one more question is from Dr. Ashish Agarwal. When to add long-acting insulin after 48 hours?
No, long-acting insulin, we would say that whenever you are planning to switch over from DK subcutaneous to subcutaneous insulin, you give it. Suppose somebody is on infusion and tomorrow you want to shift over to subcutaneous insulin, you give a long-acting insulin at night. That will make your life much easier and make it much easier in that regard. This is now clearly recommended and better in that situation.
So one question is from Dr. Dharmeen. He has written, during COVID pandemic, due to lack of regular follow-up, many diabetic patients landed up to DK in our hospital. Yes, I think he's sharing.
That's a true situation, and basically that's why remote management becomes very, very important now, to connect to the patient and technology which helps them to manage those problems in sick day, importantly.
Yeah,
One question. Yes,
Dr.
yes, sir.
Manisha and Dr. Bajpayee, we would like to share our experience. During this COVID pandemic, our hospital was declared COVID hospital, dedicated COVID hospital. So we are not admitting any non-COVID patients. So many of our known diabetics who were otherwise stable due to lack of follow-up, they landed up in TK, or even if they come to our hospital, we could not admit them. So they had a lot of complications. So regular follow-up is very important, and nowadays we can use technology, because earlier we never used to give our email IDs or phone numbers, but now we have started giving that to these patients. So now we can use their.
Yes, sir. Yes, sir. So one question was there from Dr. Kayam Rizvi, which is better guideline to follow, BISPAD or ISPAD?
Yeah, as I said, ISPAD is more suited for more severe cases. So the sort of severity that we see, BISPAD is not good in terms of it will cause persistent dehydration. We tried in a couple of patients. If you have a mildish DKA, you are more concerned about central edema and those things. Maybe that is better, but severe DKA, the fluids are not enough to really cover for that. So I will stick to ISPAD.
ISPAD, yes, sir. So one question is from Ravi Adlakha. I think it's from first session. Why not to evaluate calculation of osmolality? This is, I think, from growth session. This question is from.
Why not to evaluate the calculation of osmolality?
No, it must be for diabetes only.
Diabetes, acha.
So calculation of osmolality. Osmolality is, so if you actually calculate osmolality, you're missing out on a number of things. So it's not going to make a huge difference. If you want to look at in terms of the hydration status, I would say uric acid or a hemoglobin hemoconcentration will be a better marker of hemoconcentration than osmolality. But yes, you can do, the osmolality is high, there is a greater hyperosmolality and the risk of cerebral edema will be more in that setting. The second part of the question he's asking about is from the first session, TTG level and total IgA. We do not recommend routine IgA level at the beginning, because only maybe 1%, in our experience, only 1% of patients who had suspected celiac had IgA deficiency. So if you do that, the cost will increase. You can do that, of course, but then the cost goes up in that regards. So what we say is that if you've ruled out all the other causes and there's a nutritional pattern, you do a TTG and then IgA subsequently, not as a first modality.
Yes, sir. Thank you, sir. So we can proceed with the next session.
So I think we had a good discussion on these two important sessions. The next session is also very, very important, and that's about the thyroid. So what we'll do is that we'll quickly brush a bit of physiology, and then we'll go forward from the subsequent cases as well. So we all know that the TRH, the thyrotropin releasing hormone, comes from the hypothalamus, which controls the TSH secretion, which comes from the pituitary to act on the thyroid to produce T4, which is basically a pre-hormone. Now this T4 is activated to T3 by the monodeiodinase 1 and inactivated by monodeiodinase 3 to RT3. So the balance of thyroid function depends upon the metabolism of the thyroxine hormone. It is not dependent upon the actual secretion. The T4 is a pre-hormone, but the hormone which acts is actually T3. And this T3 and T4 are bound to the thyroxine binding globulin. Higher the binding globulin, you will have higher total hormones, but your free hormones may be normal. Similarly, if you have a TBG deficiency, you will have falsely low total hormone despite having a normal free hormone. So you're bothered about free hormone, but you are measuring total hormone in that setting. This FT3 then acts on the thyroid receptor and it causes the control. So now in this setting, the next question which comes out is that which would be the best test, the best hormone to look at. So if you talk about thyroid, the options include TSH. TSH has got a lot of diurnal variability and an interday variability. But if you really talk about from a patient's perspective, you can do TSH any time of the day. So if your patient comes to you at the afternoon, you can do the TSH then. Don't need to wait to do a TSH the next day. If somebody comes from the village, you can do it right away in that perspective. T4 is a good marker. So if you have primary hypothyroidism, your TSH will go up first, then you will have fall in T4. T3 will be the last to go. So T4 will be a good indicator of overt hypothyroidism. If it's a problem in the hypothalamus or the pituitary, your TSH will remain normal or low. Your T4 will go down. So T4 and TSH are the most important. T3 is the least reliable marker of hypothyroidism. Its role predominantly is in the setting of thyrotoxicosis. So if you want to evaluate somebody with suspected hypothyroidism, I would say you do a free T4 and a TSH. If you want to evaluate from the perspective of a thyrotoxicosis, you do a T3, T4 and TSH. Now, what you need to understand is that if you have primary hypothyroidism, your TSH levels will go up, T4 will come down, T3 will be the last to fall. And this is the classical manifestation. So in hypothyroidism, T4 and TSH is the best marker. In thyrotoxicosis, your TSH will go down and T4 will go up. T3 will also go up. In that setting, you do a T3, T4, TSH. So these are the investigations. If you want to do, you can do any time of the day in somebody who is not on thyroxine treatment. Now, how do you interpret? You need to remember that there is a huge change which happens in thyroid hormones. And this is basically at birth, there is a big peak. So if you want to do a neonatal thyroid assessment, it should be done only after 72 hours, should not be done in the first 48 hours. There will be huge confusion because of the surge. Body is wanting to fight the cold, which that's why they're having these things happening in that regards. So if you want to do a neonatal screening, do it at cord blood or better at day 3 onwards. If you're doing 48 hours and beyond, the peak tends to be higher. In that regard, so you have to use a higher TSH cutoff, and we'll discuss about that a bit later in that setting. So if you talk about the TSH cutoff, when should you worry and how should you treat? In the first week, if the levels are more than 40, treatment is required. Concern if it's more than 20. In the second week, the level becomes a bit different. So if in that situation, it is 10 and 20, and beyond 6 weeks of life, it is 6 and 10 in terms of concern and treatment. So 40, 20, 10 would be what you consider in terms of treatment in that perspective. But beyond 18 years, of course, you go into the adult of 4.5 in that situation. So you need to decide about the TSH level at the particular age to decide about evaluation in that perspective. So how do you interpret thyroid functions? You do FT4 and TSH. There is a log linear relationship between FT4 and TSH. If your FT4 is low, your TSH should be more than 100. However, if your FT4 is low and TSH is not that high, it is central hypothyroidism. If your FT4 is low, your TSH should be very high, above 20. This is primary hypothyroidism. But if your FT4 is low and TSH is below 20, so it may be reasonably high, it may be normal, but it is inappropriately low for the level of thyroxine. This is central hypothyroidism. Very important to identify, because if you give them thyroxine, they will have adrenal insufficiency and they will go into shock. So always measure FT4 and TSH together, and that will give you the diagnosis in that perspective. If your FT4 is high, your TSH should be 0, and this is thyrotoxicosis. If your FT4 is high and TSH is detectable, this is a very rare situation which you don't need to bother. So always look at FT4 and TSH. That will give you a diagnosis in that perspective. Now, how do you act as far as neonatal screening is concerned? So if your TSH level is more than 40, you have to confirm it and start treatment right away. If your TSH is less than 20, in that setting, and if you're doing it in day 2, more less than 34, In that situation, more treatment is required. So 20 is the cutoff for screening. If it's 20 to 40, you follow up after 2 weeks. If it's more than 20 here, again start treatment. 6 to 20, you can consider treatment, and less than 6, you have to follow up. So again, the cutoffs of 40, 20, and 6 are what we are looking at in terms of treatment for first week till 21 days, and then after that, you use this cutoffs to evaluate. What about primary hypothyroidism? So if you have a child who comes to you with a TSH level, if the TSH is more than 10, generally you have to treat. If the TSH is less than 6 or 6 to 10, look at FT4. If FT4 is low, this is central hypothyroidism. You have to treat appropriately. If it's normal, so if you have just a marginal TSH elevation, look for TPO, look for goiter, look for growth failure. If they are there, then you treat, otherwise you don't. So basically, a lot of these patients who come to us with TSH between 6 to 10 do not require treatment unless the FT4 is low, the TPO is positive, or there is a goiter. This is what the key message is in terms of hypothyroidism evaluation. So we've got multiple thyroid tools in our MediClasses app for congenital hypothyroidism, acquired hypothyroidism, and thyrotoxicosis. You can access them through our app. So now I'll invite Dr. Naveen to come up and start off the discussion. So Dr. Naveen is there. So we can start off this case, Dr. Naveen.
Am I audible, sir?
Yeah, you're audible. Please go ahead.
Yeah. Looking at the first case, the day for child, the TSH of 22, which are found to be high. So we decided to repeat it after 2 weeks, since it was between 20 to 40. So after repeating on day 4.
There's an echo there, Naveen. So maybe if you're having two, the system is
Just a minute, sir.
Yes, sir. Now is it audible, sir?
Yeah, it's much better. So please go ahead. So we have a day 4 child TSH of 22. What will you do, Naveen, from here?
Sir, since the TSH value is between 20 to 40, so we need to repeat on day 14, sir. Again, we repeated. It was found to be still elevated. So now we have to start thinking of treatment, or else we can repeat it and follow and repeat it after 1 week. So after on day 21, it was found to be still high. So we started fighting for the etiology. So we decided to both a functional as well as an anatomical assessment. So functional showed normal FT4 levels. So the thing is, the next we need to go in for radio uptake. So when we did a nuclear scan, it showed hemiagenesis. So when we are considering isolated elevation of thyroid troponemia, so we need to consider doing a assessment to find out the etiology such as mild dysharmogenesis, hemiagenesis, or non-thyroid illness. In this case, when we did a scan, we found that it was hemiagenesis, and we started on thyroxine.
So I think this is a very good message that if your levels are persistently high, you have to look for cause, because otherwise there will be a confusion which may happen. And so you have to use specific criteria in that regard. Now next case, a 20-year-old girl, the TSH was 28. What will you do, Dr. Naveen, here?
Sir, since it is done the first 3 days, it's not reliable. So we need to repeat it after 72 hours. So when we repeated after 72 hours, we found that the TSH was 8. And in this case, we need to reassure, and we not start treatment right now.
So suppose this was done at 26 hours or something, what would you have done then?
So 26 hours, sir, about 34 is the ideal to start treatment, sir. So we need to start it, repeat it after 72 hours, and we need to confirm whether it is elevated.
So again, the big message is please do not do a very early TSH, because that will cause more confusion in that regards. And if you have done it, repeat it. Don't start treatment on that. Suppose it was more than 100 also, I would like to repeat and get a FT4 done before we start treatment in this setting. Now, day 10 child with TSH more than 100.
So this is definitely a case of congenital hypothyroidism. So we need to start treatment. So before we start treatment, we need to look in for the cause. So basically, we need to do a scan which showed no thyroid disease. So there could be a two possibility in this case. So it could be either agenesis or it could be either because of maternal transfer of antibodies. So next we plan to do a USG in this case. And USG showed the presence of thyroid. So in this case,
carry on.
So in this case, so we need to ask for history of mother having any history of hypothyroidism. So we found that the mother was having hypothyroidism, and this could be a transient hypothyroidism because of the transplacental transfer of antibodies.
So this is very important that scan should be done. If scan is not available, do an ultrasound. Now, many people will say our radiologist is not good enough. He has not done a lot of neonatal ultrasound. See, thyroid in newborns are big for their size on the neck. So it's very easy to identify. So they will be able to tell you whether the thyroid is there or not. You're not bothered anything else. So if you want to do ultrasound, it really gives you a good picture. Scan does not show a thyroid, but ultrasound means there is a maternal antibody which is crossing and causing these problems, and mother had hypothyroidism. 12-year-old boy with obesity, weight was 160, weight was 70, height was 160, TSH 7.91. I think we discussed earlier.
We already discussed this.
What do you think about this case?
Yes, sir. We already discussed with Pratik sir when we are discussing about growth. So in this case, it was not because of hypothyroidism. It was basically because of obesity induced elevation of TSH. So we need to advise him on weight reduction and diet management. And we need to follow up with the thyroid function test.
So you can do a FT4 and TPO. If both are normal, then nothing needs to be done in this setting. Just follow up with what is required in this situation. So again, this is the effect of obesity, not the cause of obesity. 10-year-old girl with poor concentration, height is slightly low, weight is low, clinically euthyroid, TSH is 2.4, T4 is low. Do you think this is central hypothyroidism?
Sir, before labeling it as central hypothyroidism, we need to do a free thyroxine level, sir. In this case, total was done. So we need to first do a free TF4, which was found to be normal. So in this case, it is not a case of central hypothyroidism. It could be because of a thyroid binding globin deficiency.
Very importantly, because central hypothyroidism is very rare. So before you label that, you have to exclude that the T4 may be falsely low in this setting. And that's why this is not central hypothyroidism. This is basically clear-cut case of just a normal level. So TPO was negative, no treatment required. So better to do a FT4 and TSH. Total hormones may be affected by a lot of other factors as well. 12-year-old girl with lethargy, height is slightly less, weight is normal. FT4, so free T4 is done, which is low. TSH is 12. So somebody has labeled her as primary hypothyroidism. Do you agree with that?
Sir, no, sir, because for the low levels of T4, we need to have TSH more than 20, as you already mentioned. So in this case, I would see whether it is a case of central. I will label this as a case of central hypothyroidism, and I will like to do a pituitary function test and rule out cortisol deficiency before starting on treatment with thyroxine.
Yeah. So on thyroxine was given, and suddenly she went into shock. The very important message is that if your TSH is less than 20, always do a MRI, always do a cortisol before starting treatment. Otherwise, you will have a problem which will happen like this in this situation. Day 12 child with irritability, birth weight was 2800, not 2200. Heart rate is 168. So there is tachycardia and there is proptosis. So eyes are bulging. What do you think here? FT4 is high and TSH is low. What do you think, Naveen?
So it is a case of thyrotoxicosis. It could be a case of maternal transfer of antibodies. So in this case, we need to look for any history of grave disease in mother, any history of thyrotoxicosis in mother.
Yeah. So mother actually had Graves' disease and radioactive iodine treatment was done 2 years ago. So this is the big message. Now the mother is normal, everybody is happy, but the antibodies are still there in the mother, which will cross and they will cause this thyrotoxicosis to happen. You have to be very careful in this setting. 12-year-old girl with tremor, high T4, TSH is low. This is thyrotoxicosis. There is thyroid swelling. There is no eye sign. Tremor is there. What do you plan from here?
So there is definitely a case of clinical thyrotoxicosis and presence of swelling is there. So we need to first do a nuclear scan to find out whether it is Graves' disease or a thyroiditis. So first I would prefer doing a nuclear scan in this case and start treatment based on you.
So again, a big message is that if you got such high FT4 and there is a thyromegaly, it is more likely to be a Graves' disease. So you can, if you can't do a scan, you can't. Last case, 10-year-old girl with thyroid nodule, euthyroid, TPO negative, reassured. I agree with this.
No, sir, it is a nodule. So we need to do rule out malignancy in this case, sir. So in this case, we need to do a USG for looking for features of malignancy, and we need to do a tissue diagnosis in the form of FNAC to do rule out malignancy.
What's the frequency of malignancy in thyroid nodule in children?
Sir, it is generally very rare in case of a pediatric population.
But if you have a nodule, there is a 7 to 14% chance of having malignancy. Yes. So if you have a child with a solitary nodule, you have to be really bothered, especially if it's euthyroid, and if you have a fixed nodule. If there is a solid nodule, always get an FNAC and you will get a diagnosis here. So FNAC is very essential in somebody who has a thyroid nodule.
Yes,
so thanks, Naveen. We have gone through a lot of these discussions with regards to growth, decay, and thyroid. Now we have got two topics left. We can either cover puberty or calcium. Which one do you think, Dr. Manisha, would like to go on that?
So we have two topics left. Any topics that you can take?
I think puberty will be quite interesting in
Yes,
that regard. We'll
Yes,
start with puberty and then we'll take from there.
Yes, sir.
So I'll invite Dr. Prateek.
Yes, sir.
And Dr. Prateek, you can take over the initial discussion of puberty and then we'll go on to cases from there. You can share the screen now.
Is my screen visible, sir?
Yes.
Okay. Thank you, sir. So puberty, as we discussed, is a very interesting topic, and it is imperative that all pediatricians and pediatric endocrinologists know everything about puberty. So beginning about puberty, we start with how it actually happens, and it all comes down to the hypothalamic pituitary gonadal axis. So it all begins with the hypothalamus, then coming to the anterior pituitary.
It's not on the slideshow mode, Prateek.
Is it on slideshow, sir?
It's not on slideshow yet.
Now, sir?
No. Is it running on your slideshow?
Yes, sir. I am playing it on slideshow mode.
It's just showing the slide directly here, not the slideshow. Maybe try to share it again.
I'll share it again, sir. Now, sir?
Yeah, now it's working. Please go ahead.
Yes. So as I was saying, the hypothalamic pituitary gonadal axis begins with the hypothalamus, the anterior pituitary, and the end organs. Those are the ovaries and the testes. So the hypothalamus releases gonadotropin releasing hormones, which acts on the anterior pituitary to release FSH and LH. These act on the end organs. Those are the ovaries and testes to produce estradiol and testosterone. Now, the HPA axis is separate from the HPG axis. The HPA axis consists of the adrenal glands, which is responsible for pubic hair development, and the adrenarche. So if we talk about precocious puberty, there could be two causes of precocious puberty. First of all, if we have some reason for increased LH, FSH, those coming to the central precocious puberty. Now, in this case, as we said, there is increased LH. So LH of more than 0.2 is considered to be central or the onset of puberty. So in cases of central precocious puberty, as we know that the entire axis is active, so we will have testes which are larger than 4 ml or like a normal puberty occurring earlier. Most of the causes of central precocious puberty are actually idiopathic, more commonly in girls and boys, but even though they are idiopathic, they need to be evaluated. Now coming to peripheral precocious puberty, basically what happens is for some other reason, the androgens are being produced from somewhere else and mostly the adrenals. And because of this, more than the the size of the testis, it is the stretched penile length and the pubic hair which increases more than the testicular volume. So here we have small testes, but with a larger stretched penile length and pubic hair. Now coming to the cause of delayed puberty, for some reason, if there is a decrease in GnRH pulses or any central cause, such as a hypogonadotropic hypogonadism or any constitutional delay, we will basically have decreased GnRH pulses leading to a delayed puberty. Now, in these cases, the LH less than 0.3 at the time of more than 14 years is indicative of a central cause of delayed puberty, irrespective of the etiology. Now, if we have anosmia, hypogonadotropic hypogonadism, we obviously know that this is suggestive of a Kalman syndrome because of the combined migration of the hypothalamic neurons along with the olfactory neurons. And the defect in this causes Kalman syndrome. Now, coming to the end organ defects, these cause hypergonadotropogonadism, and in this, high SH is more indicative of an end organ damage. So low LH in central and high FSH in peripheral causes is what we should be looking at. Now, pubertal progression, of course, this is extremely important, and this should be evaluated by everyone at any visit whenever a girl or boy comes to us. So beginning with the pre-pubertal, the breast staging one means there is no pubertal development, no breast development. A small formation of a small bud, a breast bud, or minimal papilla elevation is known as, it's called breast 2. It indicates the beginning of pubertal progression. Now, very important and very common issue we get here is the presence of lipomastia. Lipomastia is simply the presence of fat in place of breast tissue. How we differentiate from this from actual breast development? First of all, we should do this because lipomastia has no significance, no endocrine significance for us. How we differentiate is basically we just approximate 2 fingers around the nipple. If there's a rubbery consistency, if we feel that we have some rubbery consistency near the nipple, that is suggestive of a breast development more than a lipomastia. So this is very important whenever a girl comes to us with saying breast development. Breast staging 2 marks the beginning of growth spurt. So now from here we have in girls 8 to 10 centimeters per year growth is there. Now B3 being the primary mound, B4 means the elevation and the formation of secondary mound. And B4 is important in 2 ways. First of all, it means if you have a girl in B4, it means there is impending menarche. So this needs to be conveyed to the parents. And secondly, the difference between the breast stage 2 and menarche is usually 2 to 2.5 years. So if any girl who presents with a menarche before 1 year after the breast stage 2, this is very important, and this is known as discordant puberty. So 2.5 years at least minimum gap should be there between thelarche and menarche. 1 year is significant. Now, this is a very important point. So after menarche, many patients come to us and they ask how much height is left. So approximately 5 to 8 centimeters of growth is still left after menarchal onset. Now, of course, breast staging 5 is the adult form. Now, this is one very important part, is that many girls at this age come with saying a wide discharge is present. So this indicates an impending menarche and the maximum height spurt. So these 2 things should be kept in mind. Now, coming to pubertal progression in boys, of course, we know that puberty in boys is measured and is seen by the testicular volume. So testicular volume less than 4 ml is considered prepubertal. The first stage of pubertal testicular volume more than 4 ml is the first stage. And following 6 months after testicular enlargement, we see penile growth, which further thickens and finally reaches adult growth. Now, in this slide, we can also see the pubic hair development, which is very minimal in breast in the stage 2. Stage 3, it is going up to the mons pubis. There is slight curling, and following stage 3, there is darkening and even coarsening. And after finally the adult growth is present on the medial side of the legs. Spur marquee, of course, we cannot see this clinically, but it marks like there is the end almost of pubertal progression and final height is almost being achieved. So, of course, pubertal, the testicular volume is seen by the Prader's orchidometer. And pubertal, as I said, is 4 ml and maximum growth spurt is around 10 ml. Now, voice change is an important part which we know, then which means that final adult height is about to be reached. Now, of course, how do we diagnose precocious or delayed? So thelarche, pubarche before 8 years is precocious. Menarche before 9.5 years is precocious. If it is, and of course, testicular enlargement before 9 years is considered precocious. Now, coming to delayed, thelarchy, pubarchy after 13 years, menarche after 15 years is considered delayed. And if there is testicular volume less than 4 ml, even after 14 years, this is considered delayed puberty in boys. Precocious puberty, now it is common. It is not like we don't see, it is quite common. 2.5% of all females and 1% of all males might have precocious puberty. What we need to understand that in females, it is far more commonly idiopathic or physiological. And only 10% women actually have a problem when it is in females, but this ratio is slightly tilted towards the pathology in males. So any male with precocious puberty, we should be immediately alerted. So coming to precocious puberty in girls, how do we define it? Any presence of pubic hair or thelarchy before 8 years is considered precocious puberty, or the presence of vaginal bleeding before 9.5 years is considered precocious. An extremely important point and a very helpful indicator about the etiology is the pubic hair. So we are going to now discuss the presence, the precocious puberty and etiology just based on the presence of breast development and pubic hair. So if we have a girl who has no breast development but has pubic hair, this is possibly a premature adrenarche, which may be present in 10% of all girls. So per se, we don't need to do anything. But if this is associated with increased bone age, virilization, clitoromegaly, or increased musculature, think of something that is coming from the adrenals, either a CAH or an adrenal adenoma. If we have no breast development, if we have no breast development, no pubic hair, but menses is there, think of some local causes as some local trauma or any other things. If we have breast development, but there is no pubic hair, and especially if the girl is short, then we should consider hypothyroidism, because as we know, TSH mimicking FSH leading to ovarian cysts, leading to breast development. And finally, if we have breast development, if we have adrenarche, think of a central cause. Now, precocious puberty in boys, we consider precocious if there is pubarchy before 9 years, testicular volume becoming more than 4 ml before 9 years. Now, testicular volume can help us greatly. Like girls with we are seeing pubarchy, we see the testicular volume in boys to basically get an idea what it could be. So if we have a testicular volume more than 4 ml, so we know basically LH is raised, FSH is raised, mimicking a central excitation of the HPG axis. So this is a central cause of precocious puberty. If we have small testes, now, as I said, we have small testes, prepubertal testes, but from somewhere the androgens are coming. So this is, and this will probably result in increased stretch penile length and increased pubic hair, suggestive of a peripheral precocious puberty. Intermediate size testes is an interesting factor. Now here what we have, this is probably secondary to an HCG dependent cause. Now, as we know, HCG mimics LH in its action. So LH activates the Leydig cells. Leydig cells is responsible for only 20% growth of the testes. So here, if there's an HCG dependent cause, what is happening here is only 20% of the testes is rising and leads to an intermediate size of testicular volume. So this is probably due to an HCG producing tumor. And finally, if we have discordant, in the sense only one side of the testis is increased or only one testis is increased, this is probably due to a testicular tumor. Now, delayed puberty in girls is also an important thing we should see. So no thelarchy by 13 years or no menarche within 4 years of attaining thelarchy, we should consider delayed puberty in girls. Again, similar to precocious puberty, pubic hair is an excellent tool which will help us to find out the cause. So if we have pubic hair development but no breast development, here as we can see, the HPG axis is affected, but the HPA axis is not affected. So that's why pubic hair is there. So isolated GnRH deficiency, isolated HPG axis problems causes this pubic hair development, but no breast development. If we have no breast development, no pubic hair development, probably a central cause could be CDGP or could be secondary to some illness. Third, if we have breast staging but no pubic hair, so adrenal androgens are not working, but somehow estradiol is coming. So this is a very interesting cause. What is happening is the androgen is probably high and getting converted into estradiol in the breast locally by aromatase, which is seen in androgen insensitivity syndromes. And finally, if we have breast development, if we have pubic hair development, but no menses, this is probably due to some local cause which is preventing menstruation from happening. So probably indocyanate or any additions may be causing this. Yes, sir.
You can now switch over the stop the sharing.
Yes, sir.
And so thanks for the discussion of setting the points. So what we'll do now is that we will have Sayan who will join and discuss the cases. So we have this 7-year-old girl with thelarchy, breast stage 2, pubic hair 1, height is 118 centimeters, bone age is 6.5 years. What interpret the results, Sayan? You are muted.
So am I audible?
Yeah, please go ahead.
Yeah, as sir, the previous, as my previous speaker, Dr. Pratik already mentioned, that if we have a referral as a case of thelarchy, we first have to confirm whether this is actually thelarchy or lipomastia. So, and as we can see, the height of the child is normal clinically. There is no pubic hair development. The bone age is normal, and also the biochemical parameters don't reveal a biochemical confirmation of precocious puberty. So we can actually confirm whether this is thelarchy or not, sir.
So I think this is the most important factor that you mentioned, that many obese girls are being referred to us as thelarchy who are actually having lipomastia. So all you have to do is to look at whether there is actually a true breast development. So you approximate your thumb and finger. If there is resistance, it means that there is actually a breast tissue. If there is no resistance, it means it's a lipomastia. So this turned out to be lipomastia. No need of unnecessary workup in everybody who comes to us with complaints of breast development, because that will cause more confusion in that regards. The second thing would be to look at the vaginal mucosa, which will be red in this case, which will go against the diagnosis of a true precocious puberty in the setting. Second case, 2-year-old girl with thelarchy. What do you think and how will you proceed?
Sir, this is this looks like a breast stage 3. Sir, and we can go in for confirming the other clinical characteristics of precocious puberty. So we can have a check of her vaginal mucosa. So to confirm whether this is an isolated thelarchy or a complete precocious puberty. So as you have already mentioned,
no pubic hair development and no periods. So will you do a workup here? Do you like to do some hormone test as well?
So clinically, for estrogen, we have to look at the vaginal mucosa. So whether it is red or pink. So if there is estrogen exposure, it can be pink. So yes, sir.
So it was on the red side, and the workup was done which showed a low LH, high FSH, and a normal estradiol. Do you think it's precocious puberty?
So it is. So the biochemical parameters don't confirm the same. So we can make a diagnosis of isolated thelarchy at this point and follow up whether this is the initial presentation of a precocious puberty.
Why
progressive
is
progression.
high in this girl?
So pardon, sir, I couldn't hear you.
Why is the FSH high in this girl?
So FSH predominance in this age group is present, sir.
So what you need to understand is that the most important parameter to look for precocious puberty, which is central, is LH. There is no role of FSH in that evaluation. So if LH is 0, I would not be concerned about a true precocious puberty, true central precocious puberty. This is basically an isolated thelarchy, very common between 6 months to 2 years of age, in which you will have no pubic hair development, vaginal mucosa will be red, there will be no progression, and usually they will settle down over time. So you need to follow them up. Ultrasound may show small microcystic appearance, which may be there, but that's not something you have to worry about. That's normal. And this is isolated thelarchy, which will improve over time. Now, this is a 6-year-old girl with thelarchy. What do you think here?
So this girl has breast stage 3. So I would like to look for other clinical characteristics of puberty, like her height. So the height is 120 centimeter, which seems that it is much more for her age. So, and you have already mentioned that her mucosa is pink. So there is estrogen exposure systematically. So I think this is a case of precocious puberty, sir. And plotting will help us make the confirm the clinical diagnosis further.
So what you can see on the growth chart is that she is tall for her age, As we said, 6 years, the height age is around 7.5 years, but the yellow dot is the bone age. So her bones are very, very advanced. So what means that she is tall for her height, for her age, but she is short for her bone age. So this is a classical presentation of precocious puberty. They look tall, but they are actually short. You need to compare this girl to an 11-year-old girl. And when you do that, you will realize how short she is. And if you do not do anything, there would be a lot of problems. Do you think this is central precocious puberty or peripheral?
So this is central, sir.
Why?
So this is because there are complete features of puberty in this case.
It's a proper order of puberty. So if it's orderly,
Yes,
it's
sir.
most likely central. And so if you go by the workup, you will find that she had bone age, which was 11 years. Her further workup showed a high LH. So this clearly is a central precocious puberty. And do you think she requires treatment?
Definitely, sir. Because she'll end up short, very short.
So we have to suppress puberty, and there are GnRH analogs which are available, which are very effective. So if the pubertal onset is less than 6 years, you definitely have to treat it. 6 to 8 years, if the height is compromised, then you have to treat from that perspective. This is the way to go forward, and she required GnRH analog. Another case, 7-year-old girl with vaginal bleeding, 1 episode, breast stage 1. So she doesn't have any breast development, pubic hair 1 and vaginal bleeding. Is it central precocious puberty or a peripheral precocious puberty?
So definitely not central precocious puberty, sir, because there is no breast development or any pubic hair development.
So what are you thinking here?
So this is most likely to be a local cause of vaginal bleeding, a non-endocrine cause, as Dr. Pratik has previously mentioned, sir.
So no breast and periods means there has to be something local. Vaginal mucosa is red, so it's not estrogenized. So this could be a foreign body, it could be a sexual abuse, it could be an infection. Workup will all be normal, and vaginoscopy showed a foreign body. So if you have a girl who has got no breast development and periods, start thinking of a local cause, refer to a gynecologist in that setting. 7-year-old girl with hilarchy, just like the previous girl. The problem here is that her height is 100 centimeters. Do you think this is precocious puberty, central precocious puberty?
So this is definitely not central precocious puberty, because in these cases, as we have already seen in case number 3, the height is much advanced for the age. So, but this child is definitely short. So there are other causes for this.
So what do you think of a girl who is short and has precocious puberty and actually has a vaginal bleeding also, which
So we
happened
need
very
to
quickly?
go in for a bone age, and then thereafter go in for TSH analysis, which is the most common presentation in this case. In
So
these
if you have
cases.
a girl who is short and who has precocious puberty, there are 2 possibilities. Most likely hypothyroidism, rarely a brain tumor causing a simultaneous growth hormone deficiency. So this girl had no pubic hair development, stage 3 breast development, mucosa was pink, and basically you did a bone age which was very retarded, and she had hypothyroidism, TSH more than 100. She had a large ovarian cyst, and the gynecologist want to take her for surgery. What do you advise?
So no surgery is required at this point. So THS is acting on the FSH receptor to cause the ovarian cysts. When the hypothyroid state stabilizes, it will regress.
So it is the effect of hypothyroidism. So a short girl with precocious puberty, a girl with ovarian cyst always do a thyroid function, and you will see that they will respond dramatically. This is known as von Wieck-Grumbach syndrome, which is basically the TSH acting on the FSH receptor. Nothing to worry about in that setting. So if you look at, she fits into puberty, she has got development which is there, and the bone age of the girl is less, it directly will point you towards hypothyroidism and check TSH, which happened in this case. Now we have a 4-year-old boy with early puberty, the testicular size is enlarged. So what do you do here?
So as Dr. Pratik has previously mentioned, the size of the testis gives a clue to precocious puberty in boys. So this is most likely central precocious puberty in this case. And after confirmation of the gonadotropin levels, we have to do MRI of the brain in all cases of precocious puberty in boys.
So the key message is that precocious puberty is more common in girls, but it's usually idiopathic. It is less common in boys, but more likely to be pathological. So all girls who have a central precocious puberty before 5 years of age, and all boys require an MRI. And what you're seeing here is actually a hypothalamic hematoma, which is a normal tissue in an abnormal place, does not require any surgical intervention. It's a normal thing. You just have to reassure them. Don't send to the neurosurgeon, otherwise they will go for surgery in that setting. So do an MRI in anybody who is a boy with precocious puberty, and in a girl, if the onset is less than 5 years, do a workup in that regards. Again, a 7-year-old boy with early puberty with small testes. What would you think of sign in this case?
So the same testicular size gives us the diagnosis at the onset. So this will most likely be a peripheral cause of precocious puberty, most likely from the adrenals.
So gonadotropin levels were low, testosterone was very high. So
Yes,
testis not producing the because it's small, so it's coming from somewhere else. It has to be adrenals. The most common cause will be congenital adrenal hyperplasia. You have to do a 17 OHP levels, which were very high. So this was a non-salt wasting or a simple virilizing form of CH. It can also be an adrenal tumor. So peripheral precocious puberty in a boy is an emergency. It could be an adrenal carcinoma also, which you have to worry about. This was like a CAH in that perspective, responded well to treatment in that regards. 13-year-old girl, now we've discussed about early puberty, we are moving towards delayed puberty. 13-year-old girl with concern for delayed puberty, no breast development, no pubic hair development. She is slightly short and her LH, FSH are low. Ultrasound shows absent uterus. So what do you think? This is Mullerian agenesis?
So the child has not entered puberty. There is no estrogen exposure. So the uterus will be small for this age and most likely will be missed by the doctor who is performing the radiology.
So very importantly, if you have no breast development, uterus is not going to be there. It will be very small and it will be missed. So doing an ultrasound will cause more confusion. It should not be done in that setting. And clearly, this is something which is a common presentation. Don't get over concerned. Reassure the parents and this will improve over time. She's just at the cusp of puberty, which we see at 13 years of age. So assessment, basically small uterus, what we need to understand is that if the breast is small, the uterus will be very small. Only observation will help in that regards. 16-year-old girl with delayed puberty, no breast, no pubic hair, height is short, weight is less. She has low LH, FSH. Do you think this is a brain tumor or there is a hypogonadotropic hypogonadism? We'll do MRI here.
Sir, it is a hypogonadotropic hypogonadism, but sir, the weight is much more affected than the height, most likely a functional gonadotropin deficiency.
So what will you think of?
So we can think of those nutritional causes like celiac disease.
Yes, so this girl is not only having delayed puberty, she's so short. She's 135. Her weight is even more effective.
Yes, sir.
Basically, what we have to do is to look at screening tests first. She has anemia, she has clubbing, and this turned out to be celiac disease. So consider celiac disease if you have a girl who is short, has delayed puberty, and anemia. A big important message, and they will improve with gluten-free diet. Now, this is again a very common presentation which we get. 14-year-old girl with hirsutism, menarche 1 year ago, periods every 2 months, and she was complaining of a mild hirsutism, and she went ahead and got an ultrasound done which showed a PCO appearance and labeled as polycystic ovarian disease. Do you agree with this diagnosis?
Sir, a menarche only 1 year ago, so we shouldn't have gone for a USG in this case because most likely multicystic ovaries and polycystic ovaries would have been mixed up in this case, as is mostly done.
So this is basically not PCOS because diagnosis of PCOS requires a multiple things. So when we talk about PCOS in adults, we say hyperandrogenism, anovulation, and PCO appearance. Now PCO appearance is out in children because these adolescent girls will anyway have this appearance. So you have to prove that there is hyperandrogenism, which is high testosterone and moderate to severe hirsutism. So this mild hirsutism does not make it PCOD. And anovulation is common in this age group, so you don't need to bother about that. So what is happening is that a lot of these girls are unnecessarily being labeled as PCOS, which is physiological hyperandrogenism, which improves over time. So don't unnecessarily diagnose somebody with PCOS in that setting. So this is PCOS is unexplained ovarian hyperandrogenism, which is there. Now we move forward towards delayed puberty in boys. 16-year-old boy with puberty concern. He had an onset at 13 years and then the puberty stopped for 2 years. He has a soft testis, 3 ml, pubic hair stage 3. He is tall. What do you think? This is constitutional delay of puberty in growth?
So the
Because boys will have CDGP anyway in most cases. So when we get precocious puberty, we said it's more common in girls but likely to be physiological. Less common in boys but more likely to be pathological. In puberty, it's the opposite. Delayed puberty is more common in boys, but 60-70% is CDGP. In girls, it is less common, but 66% have pathology. So in that context, this boy, don't you think this is classical case of CDGP?
So definitely not, because the child is not short. So the child had an onset of puberty at the right time, then stopped. And there is one more point, sir, has a pubic hair development stage 3. So these are the factors going against CDGP, sir.
So if you have CDGP, you should have no pubarchy. Your puberty should not start. You should have a compromised growth. So all of this is not there. This is not CDGP. You have to start thinking of something else. And this could be a sinister pathology like a craniopharyngioma. So delayed puberty can have a mass lesion, which can be a cause in boys, especially if it's acquired or a stalled puberty that you see from there. 17-year-old boy with again delayed puberty, onset 12 years, now stopped for 3 years, testis is 2 ml firm, there is gynecomastia. What do you think, Sayan?
So having the firm small testis and gynecomastia is a clinical diagnosis of Klinefelter syndrome, sir.
So LH and FSH were very high and karyotype was done, which was basically a XXY. So this is a classical case of Klinefelter. So if you have a tall individual with gynecomastia, small testis, do a karyotype and a FSH, you will get the diagnosis there in that regard. So I think thanks a lot, Sayan, for the discussion. And probably we have discussed now 4 major topics over this period of around 2 hours. We'll probably now take up some questions, Dr. Manisha. I think we can close it at that after the question. What do you think?
Yes, sir. Yes, sir. There are some questions in the question answer section. So one question is from Dr. Vivek Kumar Gupta. When we should start monitor for end organ changes, diabetic retinopathy in type 1 diabetes and renal changes.
Okay, so normally if we talk about the guidelines with regards to complications, we're talking about a period of at least 5 years if there is a pre-pubertal onset and 2 years of guidance if it's a pubertal onset after the age of 11 years. So we should do the monitoring after 11 years of age in that regard, and that will be the one which basically will give you the picture. So after 11 years of age and 2 years post-pubertal, 5 years pubertal, you start doing the nephropathy, retinopathy, and lipid and other parameters. But very importantly, also measure TTG annually. Celiac is very common in type 1 and TSH annually as well.
Thank you, sir. The next question is from Dr. Ashish Agrawal. Morning sample or empty stomach morning sample for thyroid function test?
Okay, so as I said, if you are not on thyroid treatment, you can take a sample anytime. It's not going to make a huge difference. We say 40%. So let's suppose your TSH is 2. The levels may be 1.2 to 2.8. It won't make a huge difference because the biological range is 10 times. But if somebody is on treatment, if you want to do both FT4 and TSH, take the sample before the medicine. So you take the sample and then take the medicine. If you want to just do TSH, any time of the day will be fine.
The next question is cord blood can be also used for screening of congenital hypothyroidism?
Yes, so cord blood is also an option, and that is something which you can do that, and many centers do that, but generally we prefer the 72-hour screening, which is better in terms of diagnosis.
The next question is, what lab should be advised to confirm central hypothyroidism?
So central hypothyroidism is simply if you have a low FT4 and a TSH which is less than 20, so that will pretty much suggest central hypothyroidism. Of course, you have to exclude the possibility of a non-thyroidal illness. So if somebody was in the emergency, in the ICU, you have to repeat the levels again. Then once you confirm that, you have to do an electrolyte, a cortisol level, a MRI to find the diagnosis in that perspective.
Thank you very much, sir. Any other question from any? Sir, I think there is one more question which has come just now. From Dinesh Kumar, FSH and LH level sample to be sent only early morning or can be sent any time in the day?
LH-FSH can be done any time of the day, but remember this is a pulsatile hormone, so this should be done in triplicate and then pool the sample. So you take it at 0 minute, 15 minutes, and 30 minutes, and then pool the sample, and you can do it any time of the day.
Next question is from Dr. Ashish Agrawal. When to advise for TPO antibodies, thyroid peroxidase?
So TPO antibodies are very specific. The role is if you have a subclinical hypothyroidism, you do a TPO to identify whether you want to treat or not. If you have a goiter, you do a TPO antibody. Otherwise, if you have an overt hypothyroidism, it doesn't have a significant role in that situation.
Sir, in one patient, I advised for TPO. He was having subclinical hypothyroidism. So TPO was raised. I started with thyroxine, but his requirements are very low. So should we stop for and again see again?
What is the TSH? What is the TPO level, if you remember?
Sir, I don't remember TPO level. TSH was around, sir, 14. TSH was 14 and FT4 was normal.
Sure. So if the TPO is actually, we need to understand the TPO should be more than at least 2 to 3 times the upper limit. So if your upper limit is 40, I would be considering levels more than 100 as significant. So if your TPO is 50, 60, it may not be that positive in that perspective. So that may be one of the case. And we do know that subclinical hypothyroidism, even if TPO positive, may revert in children. So if you are on a very small dose, you can try to stop it for some time and repeat it after 6 weeks. And that will be the best way to go forward in that situation.
And also we are having problem in various labs are giving in different units, sir, these values. And usually what you have written in milli international unit. And we are getting in picograms and various other nanograms. So how to convert this international unit, sir?
TSH, they use the same units pretty much. So if you get the results, you can use it. For T4 and FT4, first of all, if it's T4 or FT4, there will be 1,000 times difference in the levels itself. So then the units may be different. And the other thing, of course, is that for T4, FT4, the assays are different. So you have to basically go by the lab reference range that they're giving, because for that lab, the reference range may be different compared to another lab. So you have to be cautious about that in that sense.
In terms of, sir, congenital hypothyroidism, if it is 40, sir, we are taking 40.
Yeah, so that's standard. So TSH is usually the same. Everybody is using IU per liter, they will say, or milli IU per ml, they are pretty much the same unit. So TSH is not a problem. FT4, T4, the units may be a problem. So picogram or picomole or nanogram, that becomes a different thing in that setting.
So what will be doing if a child comes, a 12-year-old child, I think 1 week back, I got a child who came with micropenis. Although he was not having micropenis, it was only the concern of the parents that he was having micropenis. And he left me and then he went again to other doctors. So many investigations were done, but it all came to be normal. Then again, he came back. Now, what can we do, sir? 12-year, his height was normal, sir. Height was normal, but he was obese.
I think you will absolutely.
And sir, his testes were also very small.
Yeah. So 12-year-old, anyway, he has not entered puberty now, and he is not in the criteria for delayed puberty. So that will be pretty much normal. If you do the workup, you will find low LH, low FSH, low testosterone also, which will cause more confusion. So generally speaking, if you have clearly shown that the size of the penis is normal, the stretched penile length is normal, there is no need for workup. You have to basically counsel them that this will improve over 30 to 14 years of age. And very importantly, if they reduce the obesity, he will improve over time in that setting. So I think this will be the key message, but very importantly, do measure the stretched penile length. You basically suppress the suprapubic fat, use a scale, measure the dorsal surface, stretch the penis, retract the pupil a bit, and then see whether it's within the reference range or not to identify the diagnosis.
And for a newborn, sir, if it is less than 2.5 and everything is normal?
Yeah. So basically the newborn, if it is less than 2, I would be more bothered if it's less than 2. 2.5 also you have to be a bit concerned, but less than 2 I'll be much more bothered. The major concern in the beginning is to first of all exclude a multiple pituitary hormone deficiency. So I like to do a cortisol and a sodium potassium in the initial phase. Second, look for testis, whether there is actually a undescended testis. So if you have an undescended testis with micropenis, that becomes a different ballgame altogether. That means it's a congenital adrenal hyperplasia with which you have got a labia fusion, which is presenting like that. Once you've excluded all that, I would basically like to wait for some time, because what happens is that you basically have a certain situation in which you may have a normal mini puberty, and the penile size will increase over time. So if there is no multiple pituitary hormone deficiency, wait for 6 months or so. If the penis is increasing, that's fine. If not, we may start considering giving a testosterone course and work up from there.
Okay, thank you, sir. Now, I some more questions are there, I think, so we can take. I think.
I think there is on the chat question about cellular pains in early puberty. So yes, studies have shown that puberty may be happening earlier, but at the moment in India, the cutoffs are still at around 8 years for early puberty as far as breast development is concerned.
Yes.
When to stop harming children? So usually, if it's actually a overt hypothyroidism, it is lifelong. But as discussed, subclinical hypothyroidism, if your TSH is going low, FT4 is going up, you may consider tapering it down and getting it down.
Thank you, sir. Now I invite our senior members, our panelists, Dr. D.K. Singh, sir. So please give your expert opinion. Sir, are you there? Professor P.C. Mishra, sir?
Yeah, it's a very informative question. In fact, it was a revision for all of us for the growth and development chapter. So thank you, Dr. Vajpayee. I think we hope to have more such lectures in future. Thank you.
Thank you, sir. So, Professor Mishra, sir, P.C. Mishra, sir, are you there?
Hello.
Ji, sir. Ji, sir.
Am I audible to all of you?
Yes, sir. Yes, sir.
It's a very well conducted webinar by Dr. Manisha. My thanks to the organizing team and to the speaker. Nice thought-provoking lessons learned through the enlightened speakers, especially Dr. Anurag Vajpayee. A good CME on pediatric and adolescent endocrinology under the IAP banner today. Such evidence are the need of the hour. Thanks to all the speakers and organizers and audience too. Thank you very much.
Thank you, sir. Thank you very much. Dr. P. Murthy, ma'am. Ma'am, are you there? Hello?
Yeah.
Yes, sir. Yes, ma'am.
We all know about Dr. Anurag Vajpayee. We've attended many of his seminars and webinars. There's been a very sort of revision and very enlightening, especially the case discussions. It has been very useful for us. And well conducted, Dr. Manisha. Thank you.
Thank you, ma'am. Thank you, ma'am. Now I invite Dr. Manish Chaurasia. Dr. Ajay Gopal has written excellent email. Sir, are you there, sir? You can come up, sir. Dr. Ajay Gopal, sir.
So,
hello?
Ma'am, your opinion.
Dr. Manish Chaurasia?
How was the program?
Dr. Manish Chaurasia, are you there?
Another I had to say.
It was
hello.
unfortunate.
I'm Dr. Ajay Gopal.
Yes, sir, Dr. Ajay Gopal.
Dr. Manisha, it was very nicely conducted. It is always a pleasure to listen to Dr. Anurag Vajpayee. For last so many years, he is teaching us so nicely. I have attended his programs at Kanpur also, and it was really always very enriching. So I'm very happy to attend this webinar. Thank you.
Thank you, sir. Thank you, sir. So, Dr. Ajay Shukla, sir, are you there? Dr. Ajay Shukla, sir? Now, I thank all everyone. Thank you, Dr. Anurag Vajpayee, sir, for being here and for just showering your knowledge to us. And we will always be ready to learn from you and look forward for more CMEs by you for our IAP members. Thank you very much, sir. I also thank all the fellow pediatricians, pediatric endocrinologists, Dr. Narayan, Dr. Prateek Sen, and Dr. Sayan. Thank you very much for helping and conducting this CME. And I thank all my delegates for hearing and listening and coming to this. Sir Anurag Vajpayee, sir, some words from you, sir.
Thanks a lot, Dr. Manisha, for this wonderful program and making it very interactive. And it was really a pleasure. And I've been associated with IAP Allahabad for over the last 11 years. I remember Dr. Ajay Gopal was the president when I had come. Dr. Ghanshyam was the secretary. And I think we've done at least 10 or more programs in Allahabad, including a full day program as well. So it's like a second home, so to speak, in that perspective. So it's a pleasure to interact with IAP Allahabad. I'll thank special words to Dr. Prateek, Dr. Sayan, and Dr. Narayanan for making it very interactive, and thanks all the audience, Dr. DK Singh, for making it very interactive, interesting. Thanks all of you.
I also thank all the panelists for just showering your blessings. Thank you, sir. Thank you, sir.
Thank you.